And now I'm happy to introduce my colleague, Theresa Nguyen, the Chief Program and Innovations Officer at Mental Health America. Theresa will be sharing data collected about maternal mental health through the Mental Health America online screening program, which launched last May, using the EPDS or the Edinburgh screening tool to detect maternal depression. After Theresa presents, I'll be back on the virtual stage to digest what she shared and also share more about the state of maternal mental health. Thank you. And with that, Theresa, welcome to the virtual stage.
Hi, everybody. My name is Theresa Nguyen, and I am from Mental Health America, and just thrilled today to be here with you to kick off the 2020 Mom Annual Conference. It's great that we're all coming together to focus on maternal mental health, given the year and how challenging it has been for mothers. I just want to let you know a little bit about myself. Mental Health America is the oldest mental health advocacy organization, but really we're rooted in our storytelling. It's an organization that fights for people who live with mental health conditions. And personally, I've struggled with depression, anxiety, and PTSD for, early in childhood. And I will say that you think depression until you have children and postpartum depression or perinatal mental health issues come up. And man, it really took me for a ride. So I know Joy and I have had many conversations about just what those experiences are like when you're struck with mental health conditions, even for someone who is really familiar with mental health conditions in general. So today I want to walk you through some of the work that MHA thinks about and looks at. At MHA, we're going to start today by just talking about what it means to take a data-driven approach. And for MHA, we look at all of our programs in MHA to think about change across the country, right? We're evaluating what programs we're implementing to look at inequity and promoting health and to build policies and public education to drive political and public will. With data at the center to determine just how we can think about taking the things we care about, like maternal mental health, and making sure they're elevated and we're receiving the right supports and that people on the ground are getting what they need. That said, when we think about data, MHA has a couple places that we're always keeping a pulse on, and I wanted to share some of that work with you. We started the State of Mental Health in America report several years ago. It feels like several years ago, but even far back as 2015 was our first report. And what we were looking at here was to analyze data trends across the country and to look at what was available across states that could be comparable to one another to understand what trends look like, and then how policy issues like parity measures, access to Medicaid, Medicare impacted the way people had access to insurance in a way that could allow, for example, a state like Texas to compare itself to Florida or California or New York in similar sizes or demographics. When you look at this data, it's certainly not surprising that we see challenges that we understand are consistent with where we know lack of access exists, right? In the South, for example, these are states where consistently access to insurance and mental health care is a challenge as compared to the Northeast. Some of the data that we've seen is that despite some effort to move the needle on this, a quarter of adults who struggle with mental health conditions and have diagnosable mental health problems report that there is unmet need for treatment. That means that for 1 in 4 individuals, even those who are actively trying to look for mental health care, they are not able to get the mental health care that they need. And this number has not changed since 2011. Similarly, this data indicates the serious challenge among our youth. And I'll be talking about maternal mental health care or perinatal mental health care. But we're seeing that among youth, even youth who are more likely to experience pregnancy at an earlier age, these individuals are experiencing the greatest disparities in access to care. Similarly, suicidal ideation continues to be on the rise. This is especially a concern for our youth, and some of the data I'll share with you later indicates just how challenging it is for especially young people who are struggling with suicide or self-harm behaviors, have challenging experiences relation to whether or not they're getting the adequate care they need for some of the most extreme kinds of thoughts and concerns that we have. So it does make me feel, you know, hopeful that more attention has been paid to moving the needle around suicide and self-harm behaviors. And so we're hoping to see that, especially in a post-COVID world, suicide rose immensely. And I think that everybody understands that now is really the time to pay attention to some of these risk factors. I'm going to turn a little bit around our data to point to some very specific data that we have around perinatal mental health. In 2014, MHA started collecting data online from our program at mhascreening.org, where people are allowed to come in anonymously and confidentially to take just a mental health screen. And some of the data I'm going to show you here is specifically in relation to our findings from the Edinburgh, which we posted in 2020. What we do know from our mental health data is that a lot of this matches census, right? MHA has been collecting data since 2014. To date, 7.5 million screeners have come to take any one of our mental health screens. And actually, 2020 was one of the highest bumps in our screening data. Our average across the years annually has been about 1 million screens a year. And suddenly in 2020, we had 2.5 million users come in and take a mental health screen. So we're trying to make sense of, what is driving that rise, how much of it is our own internal work, and how much of it is COVID and the stress that's experienced. What we do specifically see from our perinatal mental health screen is what I find interesting is that we're not just screening among people who identify as female. 17% of our screeners identify as male. And that really says something about how much our perinatal mental health work can expand by thinking about whole family supports as fathers or male members of the family identify a role that they can play in supporting, whole family health. That said, even among people who screen for, depression, anxiety using the Edinburgh, 85% score that depression is probable. And, almost 50% report that they have suicide or self-harm thoughts while they're struggling with depression. And so what we know is happening among our screening population is that we're not tapping into people who think that there might be a problem, but they're not really sick. What we do see, and that is consistent across all screens, is that people are coming because they absolutely know something is a concern and that they're not screening mild or moderate. They're screening on the severe range across all of our screens. When we ask perinatal mental health screeners whether or not they have access to insurance, more than our other screeners, individuals who do take the perinatal mental health screen say that they have access to mental health insurance, right? 64% say they have access to insurance, but 64% report that they are not currently receiving treatment. So I think that won't be surprising for a lot of our folks who work as providers, providing access to care, because before, as I know that I'm struggling with an issue during this time period, there are so many barriers to navigate to get to that point where I can get treatment. Disclosure to my provider, to have questions about breastfeeding. I'm also just exhausted. And when do we see our provider? These are questions that I know we've addressed with 2020 Mom many times over. What are the protocols that we've established to make sure that we can adequately support parents in these early stages, particularly I think in the first 2 weeks post delivery and then 6 weeks post delivery. And then one question I always get from reporters asking about perinatal mental health is, how long does perinatal mental health last. And it's striking to me because when I talk to users on the back end, many people will say, I'm not sure 18 months in, 2 years in, if I feel quite the same. And how do I know where my my postpartum, perinatal mental health issues that have arisen just bleed back into a regular depression, or what's happened to me? And I think it's an interesting dynamic, and probably a lot of parallels as well to a post-COVID world, what we see with people who struggle with long hauler symptoms, for example, with COVID. When we asked people what some of the main contributing problems to their mental health problems were, you see that in a COVID world, isolation consistently was at the top. I will say we had sneaking suspicions that this was the case prior to COVID, and probably exacerbated by COVID, that isolation and loneliness is a major contributor to mental health challenges. And some of the policy discussions about what can be done has been around whether or not nurse, family practitioners, or any kind of mental health professional could do a home visit. Some parents who have access to for example, to doulas who are able to provide home visits might be better able to capture people who will struggle with isolation, and then exacerbated depression or anxiety or psychosis symptoms because of perinatal mental health issues. And there is a great opportunity to explore a policy agenda to support, the increases in loneliness or isolation that may also lend themselves to, for example, changes or risk factors for suicide or self-harm behaviors. And so this slide just gives you a glimpse of just the scope of what people are experiencing as part of their challenges.
Can you tell?
And finally, the opportunities that exist from this data is also to explore disparity and race equity lens to this. We see a lot of parallels across our perinatal mental health screeners with our general screeners. And when we look at people's main concerns across race and ethnicity, Black and African American screeners cite financial concerns at the highest rates. Native American screeners report immense trauma, and Latino and Latin screeners report real concerns about COVID. This makes a lot of sense given what we know about systemic racism, institutional barriers that exist for people to get well. And I will just note from a data perspective that the disparity for these populations are not minimal. It's not just a few percentage points. When Black screeners report they have financial concerns at the highest rates, those rates are at the level of about 10 percentage points different than other screeners. And so this really indicates some measure of systemic challenges that are faced by screeners. And the last two slides I'm not going to go over because I just want to give it to you all as a resource if you want to go to download them. But the next two slides are just a glimpse of the kinds of resources that we have available to us on the screening tool. They are free and accessible. And so if anybody is interested in sharing this resource with your network, we have pulled together resources for mothers and individuals, youth, et cetera, who are struggling with concerns. And all of that is free and available on our list. And here's my contact information, but we're going to turn it over to Joy.
Well, hello again, everyone. I'm so glad to be with you. And Theresa, thank you so much for your remarks. We're really excited about having this new set of data for maternal mental health disorders. And there were a few things that resonated with me that both give me hope and make me think about implementation. And the first and foremost, is the unmet need. You shared that 1 in 4 people are actively trying to find help for mental health disorders and they can't find it. That's troubling, and that hasn't changed since 2011. You also shared that 64% of our population have either Medicaid or private insurance. They have healthcare coverage. That to me still isn't enough, even if it's more than the general population that takes the Mental Health America screener. I'm guessing others thought the same thing. That's good, but more work to do there. And yet a different 64% still say that they have concerns about accessing treatment. It also really sat with me that this is a serious problem among youth, and youth are becoming childbearing age women, right? Very much a problem with them accessing treatment. That made me pause to think about why, what are those barriers, and that they have the greatest struggle accessing treatment. And can we fix that before these youth become childbearing age women? Suicidality, don't need to say anything more. And then differences as to why different races and ethnicities are struggling. Such important insight there. And then finally, that 2020 was 2.5 million users on the site for maternal mental health disorders. That's versus 1 million users on average per year. And you also shared that 17% of the screeners were male, which is really interesting. Are they completing that screener for themselves, which wouldn't be surprising that they're struggling during this time as well, or for their partners? Really interesting data. And then isolation, of course, a real struggle during COVID, now more than ever. And as you mentioned, that this was a problem before COVID. And we get to hear about this on another panel discussion of Fireside Chat tomorrow. So I'm really excited to hear from two of our speakers on isolation and loneliness. And then I really appreciated your comments about home visiting and how do we connect with mothers, whether it's virtual home visits or live home visits, and that nurses, doulas, and certified peer specialists perhaps can play a role. So thank you so much. And I invite all of you, if any of those words resonated with you as well, go into the chat in Whova and let's talk together. You can also ask Theresa questions in the chat or use the Q&A feature in Whova as well if you have additional questions for Theresa. I'm now really excited to present more information about the state of maternal mental health. And here we go. All right, well, thank you again, Theresa, and it's my pleasure to just tell you a little bit more about the landscape, the national landscape in maternal mental health, what's been happening in the last several years. So I always like to start with a few statements. I like to start with these did you know comments. Did you know that women in their childbearing age years account for the largest group of Americans with depression? Did you know that the American Academy of Pediatrics has noted that the prevalence of depression and anxiety in teen girls is skyrocketing? Did you know that maternal depression is the most common complication of childbirth? That's without the other disorders like anxiety, psychosis, PTSD. And there are more new cases of mothers suffering from maternal depression each year than women diagnosed with new cases of breast cancer. And despite all of this and the large prevalence, maternal mental health disorders still go largely undiagnosed and untreated. And that's why we're here. I also wanted to start by just talking about the words that we use. And why does 2020 Mom use the word or term maternal mental health? And I know all of you know that there are other common terms like postpartum depression or PPD. This was the disorder that was first researched, and there's a large body of evidence around postpartum depression. And for that, we're grateful. But we also now know that depression and other disorders can onset during pregnancy as well, and that there may also be pre-existing untreated depression, anxiety, etc., that exist prior to pregnancy. So postpartum may not be the right term to use when we're defining this time frame. We also really think that, and have heard from various mothers and providers, that there's this notion of do no harm, that we can't use the term postpartum depression as an umbrella term if we're really referring to the range of disorders, as it can confuse not only moms who may not be suffering from depression, but perhaps anxiety or psychosis with waxing and waning symptoms. Depression is not helpful in that sense. You'll also hear the term perinatal mood and anxiety disorders, which is often used by clinicians. And what happened several years ago, actually on this stage, is we learned that our fellow organizations, including Mental Health America and the National Alliance for Mental Illness, that any acronym, if we're going to use an acronym, which most of us do when we use this long term, any acronym that uses the word MAD in it is just a no-no. So you're going to start to see, and may have already seen, a movement away from that term, at least when we're talking with the public and mothers. So what about maternal mental health and maternal mental health disorders? This is why we started using this terminology at 2020 Mom, and so many others are as well. It's easier for clinicians and non-clinicians to understand what we're talking about. It leaves out no disorder or time period, and it also offers hope. I'll also just quickly share that we focus on maternal mental health, but also want to acknowledge that fathers can suffer from these disorders as well, and additional efforts need to be made to support fathers. I wanted to share just a little bit of background because I don't know if all of you, all now 900 of you, know that we have issued, with support from partners, including a funder, the California Healthcare Foundation, and many experts from around the country, issued what we called State of the State reports in 2017 and 2019. These reports included background information, which you can see up on my screen now, including the range of disorders, the period in the middle that we need to be thinking about, and also important information about barriers to care and pathways to change. Wanted to make sure that you're aware of those reports because much of what I'm about to share next is actually anchored in these two reports. They included both federal and national data and background information applicable to everyone, and they also focused on some of the work that was happening in California. This might be helpful to those of you outside of California as well if you're interested in doing more work at a state level, and we're interested in supporting you if that's the case. So let me start by sharing what we believe. And this is really what you would see if you unpacked these reports. First off, there's no simple answer, right? Or we all wouldn't be here. There's no simple answer. And what we really believe at 2020 Mom, and one of the things that I think our expertise lends itself well to, is that we believe the healthcare system should work. If all of us who have coverage or are supporting coverage of new moms of healthcare benefits and mental health care benefits, we believe that the system should work for us. We're paying into the system either through our employer coverage, private coverage, our personal pockets of society, and we believe the system should diagnose and treat. If we're paying for this coverage, the system should work. We also believe that there's a real urgency around addressing treatment shortages, that what we often hear that all we need to do is screen, screen, screen. Well, screening can't happen and doesn't happen without appropriate referral pathways and support for screening providers and those who screen positive. We also really believe that treatment shortages of reproductive psychiatrists, the reports that I just mentioned, highlight in the U.S. Where we have gaps in reproductive psychiatry. Thank you to our partner, Postpartum Support International, for helping to lift up those gaps. We believe we need more reproductive psychiatrists, those with specialized expertise in treating women in this time frame, and also therapists who are qualified and certified peer support specialists, which could include doulas who are trained and able to support women during this time. We also believe, like I know all of you do too, that obstetricians, which are the home base for primary care during this time, and we mean both OBGYNs and midwives, obstetricians. It can also include family practice doctors who are delivering babies, which still does happen, particularly in rural areas. We believe obstetricians should have increased capacity to support not just diagnosis and treatment plan development, but also treatment for mild to moderate depression and anxiety and what that might look like. The next pink line talks about the fact that providers must be educated and tested to do no harm. Last year at the forum, one of the providers on stage said, if you're not trained, you're actually doing more harm and you don't know it. And so providers, we find, don't know what they don't know unless they've been exposed to this topic. We also believe that it's really important for proficiency to be tested and these types of things to be baked into board certification, including the ABOG board certification program for obstetricians or OBGYNs, for example. I also feel like I need to give some great credit to Postpartum Support International at this time for developing a credential for therapists and other providers, mid-level providers, to become trained and tested for proficiency. Thank you, PSI. And then the last thing on this slide is to talk about the key role of payers, so health insurers and Medicaid health plans, and hospitals in scaling change. We use the term hospitals as the hub of birth. In the US, whether we like it or not, hospitals still deliver 99% of babies in this country, and so really can play a key role in educating moms, families, and staff, and also MDs and obstetricians in the community. We also believe that insurers have an awful lot of levers that they can push, including incentivizing desired actions. Do we want to see screening? Well, how do we make sure that providers are made whole for those efforts? Quality monitoring. How often are providers actually screening for maternal mental health disorders? And building adequate mental health networks, which we often hear is a significant problem in mothers and others having to go outside the health plan system to get care. All that to say, that's the healthcare system. There's work to be done, but we also recognize, and I know all of you do too, that we need to move upstream to provide social and practical support as well in addressing social and practical determinants of health. We'll be talking about social determinants of health tomorrow on another panel. I can't wait to hear all of those experts dive into this more deeply, but essentially what we're saying is it doesn't matter if we treat the top of the tree if we're not treating and preventing problems underneath at the root. So what do professional and clinical associations say about maternal mental health? This is helpful for all of us to get background. And essentially, the highlights are everyone believes that this is important, all professional clinical associations. And we first have to applaud the American Academy of Pediatrics for recommending early on in their Bright Futures recommendations that pediatricians be interested in the postpartum period in mental health and help women become aware of any struggles and help them connect to treatment resources. There's been an effort to increase screening rates among pediatricians as well, which we applaud, and it all started because of the American Academy of Pediatrics. The American College of Obstetrics and Gynecology, a great partner of ours, and all of the other nonprofits and leaders in this space, in 2017, rewrote their position on maternal mental health or postpartum depression at the time, and now recommends screening happen for depression and anxiety. The point about anxiety was made even clearer more recently by ACOG, at least once for those disorders during the perinatal period. They also, and you'll get to hear more about this on Friday, they also reissued a position on redefining and redesigning postpartum care, the fourth trimester, to expand to meet a woman's needs beyond just that one visit postpartum or two for a C-section. Again, you'll get to hear more about that on our final panel on Friday. And so you all have heard about the U.S. Preventive Services Task Force. This is the task force that was put into place with the Affordable Care Act 11 years ago. And this task force is asked as a part of health insurers covering preventive services. The task force is asked to review all the literature around preventive health services and identify which research shows that there's a need for a preventive screen or preventive service so that insurers have to cover it at no cost. So the U.S. Preventive Services Task Force did come out shortly after ACOG updated their position. Thank you, ACOG. We think one thing had to do with another. And they now recommend that pregnant women be screened for maternal mental health disorders and postpartum women as well. They also came out shortly after that point to recommend that treatments for prevention of maternal depression and screening to see who's at risk be covered by insurers. This is a great step in the right direction. In a minute, though, you're going to hear from me that this isn't enough to change the landscape and actually help make these things happen. That's a great segue for me to share with you. The Agency for Healthcare Quality and Research, AHRQ, shared in 2019 that for all adults, not just those with maternal mental health disorders, we're still really seeing a lack of screening happening for depression. And this despite a recommendation that not just for maternal mental health, but for the general population, that providers screen for depression. So let's move on to what about insurance and these recommendations that insurers cover these screening activities and even prevention of maternal mental health. So first, I want to just acknowledge that the Affordable Care Act turned 11 this week, and it is the reason why so many more people have coverage now in the United States. That's important. And we think this is foundational, that healthcare coverage should absolutely be available to all women. And I like to use the analogy of a fire department. Fire department's available or a fill-in staff for a fire department in our rural community. If a woman's house was on fire, someone would come help. And we believe that a doctor and mental health treatment should be available too for her, and that coverage should be there if her mind is on fire. It's foundational, but it's not enough to ensure that the system's going to work. So states also now, as of just a few weeks ago, can more easily extend Medicaid for pregnancy Medicaid, the pregnancy Medicaid population. This is essential as Medicaid would term at 6 weeks postpartum and still is terming for so many women at 6 weeks postpartum. Half of our population in the US is insured or receives coverage through Medicaid. And so now with the support of, you can read this blog post snippet on the side of my screen, with recent support, states will now be able to receive a federal match to extend postpartum coverage through 12 months postpartum. So women who are suffering from maternal mental health disorders are more likely, hopefully, to be screened because their providers won't be afraid they won't have access to treatment, and then, of course, have access to treatment through this extended Medicaid coverage. You've already heard me say it, that coverage matters and these positions by associations matter, but it's not enough to ensure that the healthcare system is going to work. There's no universal system of care or standard. We're really leaning on independent providers to be trained and informed about these disorders on their own time. We always say there's no Starbucks infrastructure. It's not predictable everywhere you go. It differs depending on where you live and who your provider is. So one more statement that I want to share. We all know that it's important to measure what you treasure, and that in our space for so long, we weren't measuring screening rates or even measuring rates of suicide among the maternal population. There has been some great efforts happening on both of those fronts, and today I'm going to cover a little bit about screening. So those associations and the U.S. Preventive Services Task Force recommends that screening be covered by insurers. It is covered by insurers. That's happening. It's just that screening still isn't happening. On the next panel, you'll get to hear our colleagues talk a little bit about some of the things we can do to see that change. We talked about already the fact that only 35% of adults have been screened for depression outside of our population or inclusive of our population, even in the latest reported data. There's also another set of data that showed from the federal government that showed primary care providers are screening the adult population or adolescent and adult population just 8.5% of the time. So regardless, the data that you see still is showing that there are significant gaps in the overall population for screening of depression, anxiety, et cetera, and that there's no difference really in what we're seeing for our population according to the research. Those of you that attended the forum last year got to learn about a new initiative that was funded by two of our sponsors, the Zoma Foundation and the California Healthcare Foundation, to fund a new HEDIS measure. And a HEDIS measure is what's used in the health delivery system to monitor how often either screening for something is happening or testing or even treatment is delivered. So it's really the gold standard of learning whether or not actions are being taken in an appropriate way. A measure was developed thanks to these two funders for pregnancy and postpartum screening, but testing is still underway, and we're hearing that that it's not been so helpful right now. The number of providers that are reporting screening has been low, et cetera. That could be in part because of COVID, but sadly, we're going to have to wait a little bit longer to see a national data set on screening rates. Finally, I'm going to wrap up with talking just a little bit about COVID and maternal mental health. As we all suspect, and as we heard from Theresa, there's really been very much in the headlines, in the news, and also through her study results, an increase in women reporting rates of significant anxiety levels or significant clinical depression. One recent study showed that rates of women reporting levels of clinically significant depression or anxiety are at 72% or 41% respectively. So significant increase from the 1 in 5 or up to 20% that we typically see. I also think it's really important to note that even prior to COVID, we would see substantial variances in the number of women that are struggling, particularly Black women at clinical rates at double the rates of white women who are suffering from these disorders. But Black, Latina, and Indigenous women now, because of COVID, are being impacted in even greater ways. You can see that there's lots of things at play here. Social support and isolation, economic consequences perhaps, increase in abuse at home, which we first saw, the research indicated was not happening, and there were lower rates of potential abuse at home. That's now not the case, we're learning. There's also this perception of risk of contracting COVID or my baby, whether it's real or perceived, and then problems with accessing healthcare delivery. We wanted to identify what came out of another report that called for really using this time of COVID to springboard into change to address maternal mental health. And that prior report, which was cited on the last page, talked about 5 S's being really cornerstone to the work for springboarding change. We added 2 of them here to these puzzle pieces. You can see we're talking about support, and we put this first, that practical support is paramount. You can't do anything else without additional hands on deck and support for sleeping, etc. Social support. So I have a family at home that can support me emotionally, physically, etc. Self-care, do I have the capacity to get exercise, like we heard from Amy as being so important to her healing. Screening, we've already talked about. Systems integration, the next panel will unpack this a little bit, but how do we further integrate mental health, including payments of mental health services, into primary care and hospital settings? Stepped care, what we mean by that is how do we help moms in a way that's efficacious and also cost-effective, meeting her with exactly the right type of care she needs at the moment. That might be the use of a certified peer to support her if she's struggling early on. It might be inpatient hospitalization, and we know we don't have enough hospitals that can support that level of care. But it looks at a stepped care approach to get mom exactly what she needs at the time. And then the last one that we love is this research body, shared smartphone-enabled services. We're really talking about tech solutions, and you'll get to hear about those solutions here in a moment too with several of our panels. I just want to say thank you. We're all in this together. It takes a village. It takes a group of change agents like you to start to unpack and move the needle, even if it's slowly but surely. So again, welcome to the forum.